think Jim mentions this on some of the videos that he has up there. I'm not sure if you guys saw them or not. There is an osteokinematic technique, which is more of a whip, okay, very similar to what we see in the foot and the ankle. That's a more quote-unquote dangerous technique to do because it's a high-speed, high-leverage technique, and we do have some vulnerable structures here on the lateral side of the elbow that could be, potentially put in a bad spot, in a vulnerable spot. So what that would look like is we'd essentially take her in this position. I'd put my medial hand over the medial side of the joint line. I'd hold on to the wrist down here at the end, and we're just going to basically flick this into adduction, looking for the momentum to create the manipulation of the joint line. Okay? Very, very effective if you get it right. Probably the most effective technique you can use. But you have to weigh risk and reward, right? Second option is basically the exact reverse of that, where you're going to come in on the ulna itself and just thrust the ulna laterally. Much safer, much less effective. The happy medium here is to get over the joint line and perform essentially what equates to an osteokinematic gapping manipulation for the opposite side. So we would get into that similar position here, but now I'm going to just be over the joint line and not on the ulna, right? And my thrust would be right through my elbow here on my right side. Okay, so I want my elbow up against my trunk. That's going to limit my excursion, right? Limit the amplitude of my thrust. If I'm way out here and I do that, I get all of this extra movement, right? That puts more risk to her elbow, right? If I'm here, keeps that short amplitude, okay? I'm going to produce a counter thrust by squeezing my opposite elbow to my side. So here, here, and then I squeeze both together in order to thrust that laterally. Okay?
With your left hand, you're stabilizing the humerus and you're moving that.
I'm just basically holding the elbow here. Yeah, it's not really doing much. She's in basically a neutral position here. Yeah. Ideally, you'd want her more towards supination, but in order to produce a good hold here, I might have to have it in more of a neutral position. It's not going to make much of a difference for what I'm doing to the ulna, in my opinion. Okay? You okay if we go ahead and fix you up here? Okay. All I'm doing here is I'm just going to give a squeeze with both arms once I find my barrier. That'll do. Not going to get a ton of joint sounds, cavitations with this type of manipulation. Occasionally you will. I used to get it quite a bit when I do the osteokinematic version of this thing. You get a nice loud crack with that. It was always a bit like, what did I just do? Okay, so we should retest our glide. That looks pretty good there. We're going to retest our quadrant. That's looking much better. Now, we've got a few other things that we've got to do here, right? We've got to check on her radial head. Let's look at pronation, looks pretty decent there. Supination looks pretty good, so superior radial ulnar joint looks okay after the fact. But we did have a distal shunting of the radius here. So the approximation technique here is something that we have to consider, because you can use this technique for, have you ever heard of the term supermarket syndrome? It's a thing that happens to children when your parents are walking you down the aisle in the supermarket and they keep pulling on your wrist, and they pull the radial head out of the annular ligament. So we can reseat that by producing an approximation. So the annular ligament has a cartilage ring on the inside of it that keeps it open. So if we can actually get the radial head to sit back into the annular ligament, then we can correct those problems. Okay, so to do that, what I will typically do, I have to fix the backside of the ulna, right? Because the annular ligament is attached to the ulna, so I have to hold that in place. So I'm going to put my hand underneath the olecranon on here. I'm going to grasp the distal end of the radius, and then we're going to produce an approximation by pressing down into the elbow. Now there's a few ways to do this where we will actually work on moving the radius into pronation and supination as we produce a kind of a deep oscillation downward, right? In order to seat that back in that ring. If we find one that's especially stiff, we can get to the barrier and then produce a thrust downward, more of a manipulative type of technique. So here and down. So bad. And then what we should get is we should get better alignment of the radius and ulna there. That looks quite a bit better. Then we would have to go back and see if we need to reseat the scaphoid. We'll learn about the techniques to correct that here in a little bit. I'm just going to go ahead and do it for her as long as I have her sitting here. Go. That one actually does pop quite a bit. Go. All right. So that's kind of the sequence, right? We have to correct the ulnohumeral problem first. Then we can kind of reassess what's going on with the radius. Check pronation, supination. You can check your radial quadrants if you want to. And then we'll do our corrections with that. Almost always, if this has been here for any period of time, we're going to have to do the radius approximation technique. And then depending on what's happened at the wrist, we'll have to do a little correction down there as well most often.
What does the thrust look like?
For the osteokinematic technique?
Yeah.
It just looks like this, so I'd take her here.
Okay, so it won't look the same as where you go.
Well, yeah, I mean, the direction still has to be the exact same. We're not doing anything different. This just has a much longer lever. It's much harder to gauge your amplitude because your hands are so loose. And what you worry about is as you manipulate this, that you go through the manipulation and hit the structures of the lateral elbow. Because it's super effective if you can get the amplitude down right, but if there, like I said, risk reward has to be kind of thought of. Now, in somebody with her particular body type, she's certainly more mobile than a lot of other folks that would come into the clinic. If I was doing this on Matt, for instance, I might not have a big deal, might not feel like it's such a big deal, or maybe even on Jerry, who has a stiffer body type to begin with, doing an osteokinematic manipulation, because their body type would be able to handle that a bit better. You have somebody with a very mobile body type doing an osteokinematic manipulation probably comes off the table right away for me. But somebody that comes in that has a stiffer body type, I might feel more comfortable getting it with that particular technique, knowing that it's going to be very effective and that their body type alone is going to actually help benefit me from limiting my amplitude. Does that make sense?
Yeah, doesn't matter what angle the elbow is in, you bring the thrust.
Yes. So you want it pretty close to extension, so I'm only maybe 10-15 degrees off of full extension here. Now when I'm doing a technique here, what I want is I want to find where the end feel is the worst. You know, very similar to when we're doing a U for a technique, we're going to find that vector where we have the most resistance to our glide, right? So similar here, we're just going to take her into various positions looking for where it's the stiffest, most restricted, where we find that pathomechanical end feel to be the most crisp. And once you find that, then you engage your barrier, produce your thrust.
Same for the osteokinetic.
It's going to be the same for any manipulation. You find the vector of the worst end feel, and you're manipulating through that vector.